So we felt like, well, let's get maybe not all the fellows on each webinar to contribute, but as many as we can. And so for those that may not be raising their hands or speaking up, we may pick on you guys. So, be aware.
Scott,
Yes.
can I say something just real quick to make sure? It may have already been said and I may have missed it, but just to make sure when the fellows come on that they introduce themselves and where they're from would be helpful.
I always forget that.
Yeah, thanks, Tree. I will put that in my notes and I promise I will say it next time.
That's okay.
Awesome. No, but that's one of the notes that we should say every webinar. So thank you. Okay. So Dr. Amy Yu, why don't you start us off and tell us where you're from?
Sounds good. Hi, I'm Amy. I'm a first-year Neuroimmunology Fellow at Columbia. And yeah, I'm excited. This is my, obviously this is only the second webinar. So I'm excited to be presenting today's case. And any other questions about me? I'm gonna figure out how to do the share screen. Okay. This is
If I can make one comment before we start, Scott and Jen, Hope very nicely introduced the awards, but while funded by the foundation, let's be clear that the voting and the final decisions are made by the faculty, not by the Frohmans, not by the foundation. It's the combined faculty. So just wanted to clarify that.
Thank you, Elliot. Good point.
Okay, great. I don't use Microsoft Teams very much. Can you see everyone can see my screen?
Yeah.
That's great.
Yeah, looks great.
All right, so I'm Amy. Very nice to meet everyone. So today's case, in talking to Hope, I wanted to kind of center more on, MS. And I have some images here, and I think I kind of want to focus a lot of our time on, imaging, diagnostics, differentials, and kind of just other thoughts. So we'll go ahead and get started. So in this case, it's a 29-year-old female. She's otherwise healthy, and basically she had 3 weeks of progressive weakness and ataxia. So in a little bit more detail about, 3 weeks ago, she just slightly felt unsteady, and her legs were just heavy. She was trying to go down the stairs, and she felt like she was having trouble understanding the depth going down the stairs. A little bit of kind of more urinary urgency, and actually did have an episode of incontinence in the setting of urgency. And then maybe notice a little bit of maybe a left hand more than right hand, just kind of a weakness. She was holding a glass in her home and they just couldn't quite coordinate or couldn't quite hold that with a hand. And then she was holding a bowl and dropped it. And then just a few days prior to coming to the presentation, she also noted new onset diarrhea, and she did endorse urge incontinence, where she just couldn't make it in time and had to, had an accident. So some other kind of just reviewing further older history, as a child, she was never hospitalized. She was quite healthy. She did endorse frequent colds and ear infections. Her sister's actually an ER doctor shared that she actually, the patient did have pretty bad menstrual migraines as a teenager, as one random thing. And besides this presentation and actually looking back, she had a couple transient neurological symptoms. The first was about 4 years ago. And, so she, a little bit about her, she, works in the creative field, does film, writes, and she was working on a large production, and it was a very kind of a high intensity period of time. But basically she was having a really bad, severe headache. And she noted that she had some word finding difficulties in that time. And all in all, it went away after within 12 hours or so. She happened to see her primary care doctor just to kind of see. And she didn't actually endorse this initially, but she was told by the doctor that she maybe had a little bit of leg weakness, which she then noticed after that for lasting for maybe about a week or so. Maybe her foot was kind of dragging a little bit when she was walking. Maybe she was limping a little bit. She does not remember which foot it was. And the doctor at that time had recommended for her to get an MRI brain, but I think ultimately because she felt better, she decided not to go ahead, not to get that. And then everything was kind of normal, and unremarkable until about 2 years prior to presentation. She just also similar thing. She had a kind of a really, she was moving apartments, and really busy, really stressed out, having to go through lots of different apartment showings and stuff like that, and packing. And she just noticed maybe a little bit of a foot drag kind of coming on again and off again. It wasn't so much consistent. It didn't really stay there for days on end, but it kind of just here and there throughout the day. And by fall of 2019, also kind of a similar stressful time period, with a lot of work duties. She just felt like the foot started dragging again. Her sister kind of shared that at this time she did, call her sister and share, like, there's a couple times she was just, hanging photos in her apartment and had some falls. Not really sure, the patient didn't endorse anything unusual. She was just hanging some pictures. But that's kind of the other episodes. Before I go on, any questions about the history? I can go on to the next slide. All right. Was there a question? I heard some noise.
No, I just, this is Scott. I opened my mic just to try to encourage fellows to ask questions, because I think there's probably some within the history. Maybe elaborate on some of the weakness. You said intermittent. Does anyone have interest to expand on that a little bit? Wow, it's quiet again. So I'm just going to pick on someone then. How about that?
I think there's some questions in the chat.
Yeah, Scott, I was just going to say people are putting some questions.
Oh, good. Okay.
Dan Pineda, do you want to ask your question?
Oh, no, it's just a clarification. Hi, my name is, it says there Dan, but I go by Mike. I am from the Cleveland Clinic in Las Vegas. Just clarifying which foot had the drop, because it was mentioned that the left hand is more weak, but I'm not sure if it's the left foot that was dropping in this case.
So in this time, the recent presentation, she didn't actually have leg weakness. It was all just hands. And in the past, when she did have a leg weakness, she actually doesn't remember which one it was. She just remembers one of them was dragging. That was kind of as best as we can get.
Got it. Thank you very much.
Mm-hmm.
And Thomas, you have a comment in there. Do you want to just ask?
Yeah, so for the intermittent foot weakness, you mentioned that it occurred in the summer timeframe. Did the patient endorse that these were worse during high heat events or during high periods of stress? Or was there any precipitating factors that led to this, or just kind of randomly?
So, she always prefaced all of these episodes by talking about stress. So she works in film, she works kind of long hours. And, I think the first time she, the way that she describes it is, I was working on a big project and I was really stressed out, and I was, writing, directing, filming, acting, everything within a film in a short time frame with a quick deadline. And that's when she had her first symptoms. So, and then the second time, the summer 2019 symptom, she was also saying I was highly stressed out. I was moving and had to, do all these different things. And it was a warmer summer in New York City. But yes, very much so in the setting of stressful situations.
I got a lot of hands up. Daniela.
Hello, this is Daniela. I'm a second-year fellow at Johns Hopkins. So I just have a question about her depth perception. Did it seem more of a sensory issue when going down the stairs, or did there it seem to be some kind of depth perception in another situation as well? And I just asked because it sounds like there's been also other brainstem issues, such as I believe you said there was some dysarthria or aphasia. Can't recall actually if it was dysarthria or aphasia. That wouldn't be.
Yeah, so, it was more that she felt like her legs were heavy and she just felt like she couldn't quite get her legs to where she wanted to go to. And going downstairs was kind of hard to navigate in terms of not seeing where the next step is, but knowing how to get to the next step. She didn't have any dysarthria on this time. It was mostly just hand weakness. But she did have that one episode of the word finding difficulty in 4 years prior to presentation, which resolved in within 12 hours.
Got it. Thank you.
Hamza.
Hi, thank you. I'm Hamza. I'm one of the fellows at UPenn Health System. My question was, looks like she had several symptoms, more of them suggesting maybe spinal cord and brainstem lesions. And one thing comes to mind, maybe NMO spectrum disorders. Did she have any visual symptoms, any symptoms that could suggest optic neuritis, or any symptoms that would suggest the person hiccups or nausea, vomiting? And the second question, in her Revivo system, did she have any rheumatological symptom like a joint pain, rash, dry eye, dry mouth, or any of those things?
Yeah, so for your first question, no eye symptoms ever. And second question, fully negative, no joint pains, nothing. And I think some of the further history will be kind of here as well.
Maybe we'll take a couple more just to
Sure.
to get the process. This is great. I love it. Zulima. I'm sorry if I didn't pronounce your name correctly.
First and last names, please, so we get both.
Sulaima, but you did very good. Hi all, I'm Sulaima. I'm a first-year fellow at the University of South Florida. So my question was about this history of like food drops and hand weakness. I was going to ask about the depth perception as well, but also any sensory symptoms, and if this was painless or painful.
So no pain. The sensory, it was more just that her legs felt heavy. She didn't actually lose sensation. There was a third point. Sorry, I forgot.
It was the depth perception, but someone else had asked the question. But thank you.
Okay, we'll take one more just in the interest of time. Gina Perez.
Yeah, thank you. Hi, I'm Gina. I'm the first-year fellow at Northwestern. So some of my questions have already been answered, but my biggest one is when she had, I know that she doesn't remember which food it was, but was it the same one that she kept getting the spells of drugging them, or was it a different one? And if it was the same, was it getting worse, or was it the same kind of severity of the drop?
So that's a really good question. I think the patient really was trying very hard to remember which foot it was, and she really just could not remember. But it seemed like it was re-experiencing the same symptom that she's already previously had.
That's what I just wrote down.
And was it the same intensity, or did she feel like it was worse each time that she got it, or was it the same?
No, I think the first time she had it was a little bit the most significant. And then the recurrent symptoms in the summer and fall of 2019 was more mild.
And did she have any bladder symptoms in the past, in 2017, 2019? Or it was only this time?
Prior to presentation, correct.
Thank you.
All right. So additional history. So, just kind of round it out, immunizations. up to date on the usual childhood stuff. The only thing is she did have a COVID vaccine 4 months prior to presentation. Nothing else. Social-wise, doesn't smoke, never smoked. Socially, we'll have some alcohol. Doesn't do any kind of drugs. She does take some oral CBD at night here and there to help with sleep. It's not a new medication that she started using. In terms of diet, she eats mostly grains and vegetables. Sometimes she'll have some chicken, and here and there she'll have the occasional red meat. Medications, none, 0. Family history, the only thing is there's a maternal aunt that does have multiple sclerosis, but other than that, she has a healthy sister, her parents are healthy, and there's really nothing else, and she doesn't have children herself. Surgical history, none. And travel-wise, in the past year, hasn't gone anywhere. She resides and works in New York City. Before I kind of go into the next portion about exam and such, any other kind of questions about history and what are kind of folks thinking? I think some differentials have already been brought up.
There's a couple questions in the chat. I'll just read them out real quick. Jackie, assuming Kashorik, do you mind clarifying the time to peak symptoms?
I'm not sure I understand that question.
Maybe the nadir dysfunction.
Yeah, I'm one of the neuroimmunology fellows at Hopkins. I was just curious, her current presentation, like how quickly did she develop, essentially what Dr. Newsom had said, going to her nadir with all of those symptoms? Was it over hours or days?
So it was over weeks, because it was 3 weeks ago that it was unsteady and like heaviness. And then it was really the few days prior to presentation where she had, the days before presentation was the urinary urgency, the hand weakness, and the diarrhea. And that's what prompted her to seek evaluation in the emergency room.
Okay, that's very helpful. Thanks.
Mm-hmm.
We have another question. Do we know the dosing of CBD?
I don't know. She takes it rarely, maybe like once or twice a month. So it's not a significant dose. I don't think so.
And one more comment, and then I think we have a couple hands. So this is a very interesting question, because I think this we probably all have to do a better job in the social history gathering. When someone says, socially drink, what does that mean? Is that, on the weekend, someone's pounding 2 cases of beer or drinking a huge thing of vodka? Or is this, when my family gets together, for Thanksgiving, I have a glass of wine. So I don't know if you can comment on that.
Yeah, so this patient, she really doesn't drink very much. It's more if there's a work gathering, kind of a social hour with work, she'll have a drink or 2, or if she's gathering with family. So maybe it comes out to maybe 1 or 2 drinks a week, something like that.
And how big is the cup, right? Is it? I'm just kidding.
Good question.
Yeah, standard size. Yeah.
Ryan has a question. You guys are great, by the way. This, we'll continue to take feedback from the group, and I know there's some silence in between the slides, but I think since we have a big group and we want to get the fellows really engaged or more engaged, I feel like this is working well. But again, we love the feedback. So Ryan.
Hi, I'm Ryan Canisario. I'm one of the MS fellows at University of Rochester. I was wondering if she had any cognitive symptoms such as fatigue and the expressive aphasia that you described earlier. Did she characterize that further? I wonder if it's difficulty with word finding instead, if we're thinking about MS.
So it was really just kind of the word finding, and she did endorse a little bit of kind of intermittent paraphasic errors, but she was able to comprehend everything, and all of that was resolved within 12 hours. I forgot your first question.
Oh, just any other cognitive symptoms such as fatigue.
No, no one doesn't endorse any kind of fatigue. You know, she works a pretty high stress job and has been doing it fine without any issues.
Mm-hmm. Or difficulty or changes in memory, attention, anything like that?
No. She's, you know, I think this is not so much subjective, it's a little bit more objective. You know, she was a little bit of a difficult historian to some extent, you know, not being able to remember which leg was dragging. She didn't remember that she had menstrual headaches as a child or as a teenager, and it was her sister who was on the phone who endorsed that. You know, is that the sister didn't say that she was concerned about memory changes or anything like that. So I think it's possibly that this patient is kind of a little bit scattered in general because it didn't raise any major flags from a family member on the phone.
I know many on the line are just dying to see the MRI. I know I am.
Okay.
So I don't know if we want to.
I think that's where the bulk of the case is going to be. All right. So I'll move on. So in terms of examination, kind of just the relevant stuff, you know, young female, mental status was, you know, kind of surveyed. Everything was basically all normal. The only thing that I just want to bring your attention to is the motor exam. The lower extremity was full strength in all distributions. And basically it was mostly her distal upper extremities that were weak. Her interossei were about 4- bilaterally, and reflection extension was 4 out of 5. And then as we move more proximally, it becomes full strength. In terms of sensory, she actually did have decreased vibration at the toes bilaterally, but she had normal proprioception of the toes, normal pinprick, and also a negative Romberg. In terms of reflex, she was diffusely hyperreflexic all throughout. She had Hoffman's bilaterally, she had cross adductors, and 5 to 6 beats of clonus bilaterally, a little bit more on the left and the right. And both toes were upgoing. In terms of cerebellar testing, you know, with her eyes closed, she had a significant trouble finding her nose with her finger. With her eyes open, she actually did not have any dysmetria. She had a mild intention tremor bilaterally. And finger taps were both slow, but maybe a little bit more slow on the left compared to the right. And similarly, in terms of kind of fine movement dexterity tasks, a little bit worse on the left hand than the right. In terms of gaits, just a touch, that's meant to be say wide-based, a touch wide-based, but otherwise, you know, nothing too remarkable. She was able to move, she wasn't swaying too much.
Scott, I have my hand up a second. So I'm going to do my once a year Don Quixote tilting at windmills. If you can go back to that slide.
Which slide?
The exam, please.
Yep.
Okay, so the motor exam 58 years ago at your institution, Columbia, no, the next one, was gait and cerebella were part of the motor. What you've described is power, actually, in a way. But here's why I don't like cerebella, if you don't mind, is you've described things that are not cerebella under cerebella. You've described sensory, proprioceptive, and slow, rapid movements are usually, if they're not basal ganglia, they're upper motor neuron, okay? And one last Don Quixote tilt, there's no such thing as a negative Romberg. It's either present or absent, but it's never negative because he didn't describe a negative sign. And no, it says, so it's my once a year. I won't do it again, Scott and Elliot, until next year if we're all around. But it doesn't make sense. In the merits exam, put all of those things, and gait, frankly, if you start with gait, the rest of the exam is easy. Because Merritt used to analyze gaits, watching people walk. Just at our Columbia graduation, he was watching the audiovisual guy and analyzing his gait. Once you do that, the rest of the exam is pretty easy. So, all right, Don Quixote, I'm done with the windmill. Thank you.
I was wondering if you missed the intro where we're supposed to wait till the end, but we like the Don Quixote. Just to that point, though, the gait, I think, you know, if you are short on time, to Dr. Lissak's point, watch a person walk, because you really can gain a tremendous amount of knowledge based on the walking of an individual. So, okay, fantastic.
All right, so imaging. So I have videos here, and I hope they work. Perfect. So I have a flare T1 and a post contrast. There's a little bit of motion, so I apologize for that.
And Amy, maybe as it goes through, can you describe to us what you see?
Sure. So, and I can scroll back as well. So, throughout the brain, significant bilateral, kind of white matter lesions. There are some areas that are really quite confluent, kind of throughout. Appears to kind of spare the U fibers, I would say, kind of fluffy some areas maybe, and really just scattered everywhere. Some kind of periventricular areas as well, but kind of bilaterally along into the occipital horn. So a lot of just confluent white matter abnormalities, and there's also some brainstem and cerebellar lesions. Sorry, the color not the best in this image, and also just kind of a pretty marked degree of atrophy for someone who's 29 and otherwise highly functioning. So in terms of the T1, part of the C-spine, there's some hypodensities and kind of going up. There's also lots of T1 hypointense lesions, and throughout the brain, multiple kind of T1 hypointense. And then a post contrast. So there's a couple brainstem enhancing lesions. There's some very kind of throughout.
Amy, can you go back to a little bit lower where there was one enhancing lesion that I think caught my attention, and be curious to what other fellows think.
Yeah, so I can scroll through around because I think this part is quite important, and I wanted in discussion. So I can scroll through the videos to a particular slice of interest. Which area?
Yeah, it was a post contrast. If you go up a little bit, right there.
This one.
So I don't know if anyone else wants to comment on that enhancement pattern. It's very interesting and something that caught my attention.
Sure, I can speak up. This is Shuvra Roy. I'm one of the first year fellows at Johns Hopkins. Certainly we see, on that right side, incomplete ring enhancement with, the open end of the ring, facing towards the cortex. Certainly the first thing you think of there is some sort of demyelinating process.
Absolutely. Not that other conditions can't cause open ring enhancement patterns, but it's always something to think about when you see that, even in, I think, someone who's got confluent lesions and maybe their history is a pretty rapid in terms of the disability that they've accrued. And I do recall, Emmy, you alluded to not only confluent, but there are some areas that are discrete, right? There are discrete lesions, which again, if you're thinking demyelinating disease, you like to see discrete lesions amongst the confluent lesions as well. That's all I wanted to point out. I don't know if other fellows have comments or you want to point out some of the things that Amy went through.
We have 10 minutes left. Just come out to let you know, Scott.
Okay. So maybe in interest of time, we'll move on.
All right. Oops. All right, and in terms of neck imaging, there's some more videos, and I can scroll through them. The T2, and then a post contrast. So, here I think you can see it best. Kind of this quite a edematous, really, T2 hyperintensity throughout the cord. It's hard to see here, but it's not quite confluent. With the better resolution, it's actually a little bit kind of like a few interval, but this one just doesn't show it very well. And I think folks will probably have a question about that. And then it's hard to get the contrast to show well, but there's a little bit of that peripheral enhancement around there. Yeah. Any other kind of comments about the imaging?
It looks like she also has some degenerative disease at that level, which is something we can discuss later in the discussion about MS lesions occurring at the level of degenerative disease. Looks like she's got some discs there also, right?
Yeah.
Yeah.
Okay. And then there is.
But the axial might show it better because sometimes the sagittal amplify the findings. The axial give us an idea.
Yeah, great point. Especially if there's edema, right, or inflammation. Absolutely.
And the axial might also help showing whether that's continuous or discontinuous.
Exactly. So I have now the T-spine imaging, T2, and then post-contrast, and then I'll kind of scroll through them a little bit more. So it's a little bit not the most clear, but there's a couple of different areas of kind of patchy signal around here, there, up there, some there, some there. So kind of really, and then maybe down here as well. And then the contrast, this one was definitely a clear one right there, and up a little bit higher. It's a little bit harder to see, but there's a little kind of a whisper of a enhancement there.
So I think what you pointed out, the skip lesions probably make you feel a little more comfortable that this potentially is MS. I would say the cervical spine lesion is, in my view, a little atypical, and be interested to hear others once we get to the open discussion. But to, I think, Jen's point, maybe there are two processes present which can happen in the same individual. So. Okay.
So next up, diagnostics, but I'm sure if there's any other kind of comments, now's a good time.
Go ahead, Thomas.
This may just be a artifact of the imaging study itself, just based off the slice location. But the cerebellum looked like there was some major degeneration of the foliae. The next image, right here. If you can, the T2 image, would you mind replaying that? Yeah, there appears to be some major lesions. Was she having any others, like symptoms other than that foot drop? Maybe like some ataxia at the level of the trunk, or maybe like some difficulty outside of just this weird little hand issue?
Yeah, I mean, she said her first symptom was feeling unsteady, and kind of going down the stairs was hard to kind of coordinate herself to move in the right way,
Okay.
but a lot of unsteadiness.
And then
okay.
Thomas, we lost your mic.
Yeah, we lost.
Thomas, are you muted?
I'm not sure what happened. What about the eyes? Were there like eye motions at all that were going on with this particular patient? Stuff that might have been grossly visible, especially with this degeneration of the cerebellum.
Surprisingly enough, it was completely normal in sharp discs. So.
Interesting.
So we have a couple more hands raised, and then maybe just in interest of time, we'll move on. Alex Gill.
Hey, yes, my name's Alex Gill. I'm one of the fellows also at Hopkins. And I was just wondering, like, you know, I feel like with that, and some comments about something similar in the chat, that goes confluency of lesions, you know, it makes you wonder a lot about cognitive symptoms. And, you know, especially with this I'm almost going to say downplaying of her prior symptoms and the suspicion that she almost certainly must have had more severe symptoms than they sound historically. It just makes you kind of wonder about kind of that cognitive piece. And I've seen like one patient similar where they, really just almost didn't understand all their prior deficits, because you'd expect some like on formal testing, I guess it's more of a comment, but I just wonder if some of this discrepancy between like what her lesions look like and how like swollen and edematous they are and how like expansive they are is kind of make me related to kind of cognitive stuff, especially because a lot of it came through her sister, it sounds like, more than her describing all these kind of prior attacks. So
yeah. So
definitely we undermeasure those in clinic. Obviously, we like our bedside testing is very like going to find major stuff, but kind of processing and more like their medical care is obviously going to be much something we're not going to get at bedside.
Yeah, and this is her first time history, first time presentation in the hospitalization. So, but definitely she didn't endorse memory things and deficits, but it was unusual that she couldn't remember which foot was dragging and stuff like that. And on
she's also young,
exactly.
So neurological reserve is, I think, a little bit more robust than, if she was a little bit older. So, but I think you alluded to neurocognitive testing would be really important, I think, in someone like this.
100%. Yeah. The one thing I did want to bring up is, this is a talk about MS, of course, but this amount of leukodystrophy kind of makes you think about, are there other disorders to think about? Which is why a little bit in the history, I included some childhood history, where it's kind of important. Are we only dealing with the demyelinated disease, or is there something else, metabolic, mitochondrial, genetic, to kind of consider with all.
So maybe we'll just take one other question and then maybe move on, because we want to be sensitive to the next case as well. Nuriel? Probably butchered your name.
Thanks.
I apologize.
No. All good, Nuriel. You got it. So I'm one of the fellows over at USC, and actually maybe piggybacking off of that, Amy, because if you wouldn't mind just another look at the brain, because I think, again, we're looking at this like, is this just terrible MS or is this something else? Can we get another look at the anterior temporal lobes? And then the other piece is, are there any truly juxtacortical lesions?
Well, there's a Brachiopontis lesion, and maybe those. Oh, there's a lot around there.
Probably sagittal or coronals would be better.
Cervical flare would be great.
Yeah. I didn't take a video of that one, unfortunately.
Thanks for getting the ones you did. These are great.
They're very good.
There was just a lot to see that a screenshot have been able to.
If you're worried about some edema in there, can you imagine how big those ventricles might be without it? It's been there a while, I agree.
And there was also a couple of comments in the chat about, looking at the spine lesions, whether they're peripherally, oriented or central, which I think maybe Dr. Lisek had mentioned. So that's definitely, I think, important in the differential.
Yeah, exactly.
Also, some gray matter lesions, deep gray, that were in there too.
Amy, do you have one or two more slides, I think?
Yep. Okay, so then I'll move on. So diagnostics, so this is her first hospitalization. She got a spinal tap, no RBCs, and she had 6 to 5 cells, lymphocytic predominant, normal protein. She had a slightly elevated glucose, but it was appropriate correction for serum. She had positive oligoclonal bands, and her IgG index was elevated at 1.08. She actually got kind of a little bit more of a broad workup, including negative lactate and pyruvate, out of my concern for whether or not there's a mitochondrial disease going on as well. Other kind of surveillance stuff, it was really just, she was found to be severely deficient in vitamin D and in B12, and along with some moderately elevated ANA and an SSB. She had a whole host of multiple other labs, notable for negative NMO and MOG, both of them. And she also had an array of kind of infectious testing that were quite unremarkable. And she did not endorse any kind of rheumatologic symptoms or other reviews. This was really good. It was really negative. And yeah.
How many oligoclonal bands, Amy? And how many in the serum?
Ooh, I think she had 2 in the CSF. I would have to, that were unique from the serum. I would have to look in the actual lab. I don't recall on the top of my head.
All right, why don't you go to, I don't know if you have one more slide and then Hamza has his.
Yep. So, you know, ultimately this is her first hospitalization. She was treated with high-dose steroids for 4 days. And by the time I met her on after day 4, she reported that her symptoms were 70% improved. I actually saw her walking up and down the stairs with the physical therapist. Unfortunately, she did have some transaminitis from the high-dose steroids, so that had to, we were stopped at 4 days. And due to her severe deficiency, she was started on B12 intramuscular injections along with high-dose vitamin D repletion. So, you know, this is a pretty new patient. We haven't seen her in clinic yet. She barely just got discharged from the hospital. Gave her a phone call a couple days after she left the hospital. She felt like she was continuing to do better. You know, every day can get a gradual improvement. And the big next question is, you know, are there any kind of diagnostics to consider? And we talked about this a little bit, differentials and choice of DMT and why.
I guess this might be an interesting test, although probably bad choice. Why don't you raise your hand if you think this is multiple sclerosis?
No.
You could do real hand or the virtual hand. Okay, all right. So everyone seemingly is convinced.
I think it's a little early to call it MS.
Brigitte said MS as a working diagnosis. Okay, I like that. I like that comment. Yeah, it's sometimes hard.
You said you're not comfortable, Hamza. What worries you?
I think when we talk about MS in general, even making the diagnosis for very straightforward cases, we always think about typical symptoms, typical lesions, and typical history. I don't think any of those fits in this case. That's one thing. We still have to rule out other things. There are some markers, for example, SSB, ANA positive. I would go a little more detail on that. Maybe we need more. We heard she didn't have any symptoms, but maybe we can get some more objective data in terms of if she has any Schimmer's test or any lip biopsy. Maybe we can consider at some point, maybe not as a first line. We can still have to consider sarcoid. I didn't see HIV in the labs. HIV can cause all of these. I think those are the main things to start with to make sure the diagnosis. But in the meantime, if she responded to steroid and we rule out infection for sure, I agree with steroid treatment initially, and it looks like she had some recurrent symptoms and lesions. If we have to put her on a medication, I would choose something more broad spectrum, something like rituximab instead of MS targeted therapy to start with.
So no better explanation for what you're seeing. That's what you're basically saying, correct? So yeah. I think it's true. You want to make sure you're diligent in working people up, especially these atypical presentations. But I will say, and I learned this from my mentor, you'll see more commonly atypical presentations of a common disorder than a common presentation of a rare disorder. And I think that probably stands true, you know, statistically speaking, but you definitely have to be mindful of that. Okay, let me just look to see Brigitte. See your hand raised, and I think you did make a comment, but I don't know if that's from the comment or you have a question. Why don't we have
we
a
want to
couple
open it up,
faculty?
but we're over time, so I don't know how you want to handle that, Scott. We're over time for Dr. Rose, but how do you want to? Should we open it up for 4 minutes?
I think so. Yeah. Why don't we have the faculty weigh in? Anna, you want to go first?
Yeah, sure. Sorry, hold on. I would not consider that atypical, although I do recognize, particularly if you look at the supratentorial cuts, if you look at somebody with vascular disease, like you can confuse that with somebody who's 70-year-old and who has Binswanger. But the minute you start going through the infratentorial cuts, then you look at the contrast enhancement and the spine, it becomes more obvious. So I think the workup that has been done so far, in my opinion, is sufficient. I will not go chase more than that, because between all the diseases we have thought about and the differential, MS remains the most common diagnosis. And here, I'm not considering it only as a diagnosis of exclusion. It's not like short of having no answer, I'm saying it is MS. It's because I truly believe it is MS. And those of us who have seen pediatrics, probably Jen, see pediatrics, we see a lot of lesions at a very young age. Probably that young girl had the disease at a very young age with very high burden of disease.
And Scott Zambo, I think I saw your hand up.
I agree with everybody, and I like to have a working diagnosis, especially one I would want to treat. And I'm don't like diagnosis of exclusion, but I'm also accepting that there are times where MS is not a uniform disorder and there's some heterogeneity, and this is probably right at the extreme of what I've ever seen. So I think you've done a pretty thorough workup, and I would agree with the broad spectrum treatment here.
May I say something?
Sure.
I just, based on her clinical presentation, I feel like she meets diagnostic criteria for MS pretty well. She has the spinal cord lesion that I think that you said, Amy, that there, when you look at it in the axial, is more like patchy. Is that what you said? That we see it confluent in the sagittal. So she has a spinal cord lesion, she has infratentorial lesion, she has the oligoclonal bands, she has contrast enhancing and non-contrast enhancing. So she really does meet diagnostic criteria for MS. I agree that it's very severe, but the positive ANA at titer of 640 is not really that high to make me think that it has to be something different. And I feel like the workup with the positive oligoclonal bands and the CSF itself is also classic for MS too. So I feel confident of saying that is MS. And also we rolled out an MO and MOG based on her other testing.
I think we're up against time. Wonderful comments. There's a few people that still have their hands up, and we'll try to make sure we get to you on the next case. I think Mike and Ryan have been patiently waiting. Brigitte, I think, had a problem with her mic, but we'll try to get to everybody on the next case. Dr. Rose, we could maybe have one final comment. Mike, I think you've had your hand up for a while. If you want to make your final comment while Dr. Rose pulls up her slides. If you're still there. Okay.
Oh,
right.
I just forgot to lower my hand, sorry.
Oh, okay. Well, that's why your hand's been up. Okay. All right, Dr. Rose.
Okay, I'm gonna try. I too am not very good with sharing my screen on Teams, but I think this
We can see it. Looks
correct.
good.
Okay. All right. So my name is Deja. I am a second-year fellow at the Mellon Center for Multiple Sclerosis in Cleveland Clinic. And I guess my presentation may be a little bit more reminiscent of last year's kind of conference style, but I'm typically going to just go through one of our hospital consults and kind of where we thought along the diagnostic pathway in each step. So here we are. Let's see. Okay. So this is a 24-year-old previously healthy man. And his course started in June 2020. Before that, he didn't have any neurological symptoms. He had a subacute presentation of left upper and lower facial weakness with some hyperacusis. This developed over several weeks. He was treated with oral prednisone, and it slowly got better, but it was still present. And then 3 weeks after this 3-week presentation, he started developing additional symptoms. He had bilateral tinnitus. He had vertigo. He also had some gait imbalance. He was falling. And then he started to notice that he had some mild right leg weakness, some more proximal. He actually sought care after he had several falls. That was the kind of first time he thought to escalate his care. As far as his medical history, this weird head trauma we were trying to pinpoint. He had a head trauma, and then they described it as he needed a surgery to get a tumor out. Maybe he had some intracranial bleeding, I'm not sure. But other than that, that was the only thing he had, the head trauma. He had a family history of a cousin with Crohn's, otherwise no autoimmune history in his family. Social history, rare alcohol use, maybe 1 drink a month, no other drug use, occasional social smoking, and then otherwise previously independent. He worked in a factory. And so this is what happened when he went to, he originally went to an outside hospital and had this MRI. And I just wanted to show you kind of how they initially got his workup before he came to us. So here I have the T2 FLAIR images, some axial. I tried to get just kind of where the money shots were, and then the T1 post-contrast images. But you can see he's got some hyperintensities, a little bit probably in the pons, but also kind of periventricular, kind of fluffy, kind of large. It looks like mostly in the white matter as you go supratentorially, but these are also associated with this post-contrast enhancement. Not necessarily true open ring, though some of them are. But also, and I didn't put these on here, he had some diffusion restriction in these areas where there was post-contrast enhancement. And then here, they officially read this as normal. However, there was concern in the report that they thought maybe there was some enlargement of the cord between the areas of C4 through C7. I just wanted to allow you to see that for yourself. But otherwise, this was not really focused on. So just from that initial kind of presentation, I just wanted to pause to make sure someone had any more questions or initial thoughts, any additional testing, or what kind of sparked your interest?
Yeah, so let's start with the fellows. I don't see hands raised, but I might be missing someone. And also if you haven't spoken up yet today, please feel free. Maya, you have your hand up.
I can go back too.
Hi, this is Maya. I'm one of the first-year fellows at the University of Rochester. Just wanted to clarify, I think the history mentioned upper and lower facial weakness. Just to clarify, is that meaning that the patient had peripheral facial weakness on exam?
Yes,
And so I was wondering if any of MRIs were done with thin cuts through the brainstem to look for peripheral enhancement?
No, it was just a regular protocol MRI brain.
Great question. Excellent.
Can you tell me what Maya's last name was?
Last name is Madhavan.
Thank you.
Excellent question. Other thoughts from the fellows, maybe some folks we haven't heard from today. I'm just picking out names here. Sarah, Lindsay, Paula. Anybody else want to make any comments? Oh, I'm sorry, there are some more hands raised. Mike, your hand's up, and then Hamza, and we'll go from there. Okay.
Hi, just any history of recent travel or any hobbies like hiking or spelunking?
I don't know about the hiking hobbies, but he didn't have any recent travel.
And this patient is in Ohio, right?
Yeah.
Like that area. Okay.
Yes. Yep.
Okay, Hamza, and then Gina, and then Dr. Lissick, I see your hand up. We're trying to save faculty comments to the end, but and we'll try to leave time for that. Hamza and then Gina.
Yeah, thank you. I was wondering if there was any historical events, and also how long was this left full face weakness lasted, and how was it ever treated or not?
Yes, thanks. This was his first time ever outside of that weird head trauma where he was hit on the head with something metal and possibly had some bleeding. He didn't really have any other medical history. He was previously healthy. And then with the subacute left upper and lower facial weakness, this kind of developed over several days and kind of got worse over several weeks. They did try to treat him with prednisone orally. I'm not sure the dose. He wasn't. We can't find that in the prior records either. But it seemed to either not help very much, or it just slowly got a little bit better. But he did have some residual left-sided weakness on his face when he developed the other symptoms 3 weeks later.
Thanks.
Okay, and we have a comment in the chat box from Dr. Harrison asking if there's any ear pain or changes in taste.
No, that's I didn't put that on there, but they were both no.
Okay. All right, why don't we move on, and we'll try to get some more folks in the discussion at the next stopping point.
Gotcha. Okay. So this is what he had done at the outside hospital. He had these labs done. They did basic labs, TSH, ACE. They checked a UTOX. They sent NMO, IgG to LabCorp. He had a nasal swab for COVID testing, and they basically just found that he had low B12. They did an echo. They did some CTA, vessel imaging, and he got a lumbar puncture. So he had 5 whites. They said it was lymphocytic predominant. We don't have the actual lab records. Slightly elevated protein at 52. Otherwise, viral and bacterial panels were negative. Cultures were negative. Lyme antibodies, oligoclonal bands were negative. There weren't any in the serum or the CSF. The IgG index was 0.6. The ACE was 51. And they did cytology. So at this point, what would you have told him? They sent him home, but before that, they gave him pulse dose steroids and some B12 supplementation. I'm interested to know what people would have told him that was going on when he was supposed to follow up with a neurologist as an outpatient. But I can tell you after we discuss it what they were thinking.
Okay. Did you want us to pause and discuss?
Yeah.
Okay. All right. So we've got a few. We've got a few questions coming in the chat box. Gina asked some good questions about hiccups, intractable nausea, vomiting.
No, he didn't have any of that.
And Dr. Zabad's asking eye symptoms, any systemic symptoms?
No eye symptoms, no systemic symptoms at this point.
Okay. And Gina, your hand's up also. Did you want to add to that comment in the chat box?
Oh, sorry, it was from before and I didn't put it.
Oh, no worries. And Dr. Yu has a question for you.
Yeah. I was curious. I'm kind of surprised that this is all they did, just steroids. Was there any kind of restriction of diffusion at all with any of those lesions?
Yeah. All of these lesions, I guess I could have put them on here. Can you see my arrow? My pointer?
I can't.
No. Okay, all right. Well, the post-contrast images where you do see the enhancement, they were associated with diffusion restriction in these areas.
Okay. And we have one final comment before we let you move on. Any recent vaccination?
No.
Okay. All right. You can go on to your next slides. Yeah.
Okay. Well, they told him that he had ADEM. And to finish the oral prednisone taper. And so, it started in June. By November 2020 follow-up, he thought that his left-sided facial weakness was getting a little bit better. He did have some persistent right leg weakness, but overall, he thought he was slowly improving. So he went back to work in the factory. And this was his follow-up imaging. This was the only post-contrast images we had available from them. This was all done locally, not in our system. But he did have resolution of the post-contrast enhancement. There were, at least some hypodensities in the T1 imaging, but overall, at least there was a decrease in the burden of T2 flare and white matter abnormalities. And so they just thought that, he was improving. Unfortunately, I put this in here because on Axial, they did not find any definitive lesions in the spinal cord, but they were concerned about some of this patchy signal on sagittal view on this T2 stir of the cervical spine, but they just kind of commented on that as possible abnormal, but it was nothing to do as far as they're concerned. So unfortunately, so that was November and he was slowly getting better. But in February, he had a reemergence of vertigo. This time it was more severe. And instead of the left upper and lower facial weakness, he had right upper and lower facial weakness. He now started developing some short-term memory issues. His mother said that he kept repeating himself. He wasn't, even though he was repeating himself, he also had a paucity of language and he had some mild swallowing difficulties. And so this time he was admitted to Cleveland Clinic, and his initial exam, for as far as they didn't do a very in-depth mental status exam, but at least he was following basic commands. I put the pertinent abnormal findings on his exam. He had bilateral upper and lower facial weakness. He had horizontal nystagmus with the fast phase towards the left and left gaze and towards the right and right gaze. He had dysarthria. His strength was intact and so was his sensation, but he did have diffuse reflexia, hyperreflexia. He had upgoing toes. And so they were preparing to send him to the neurology service at that point, but he had a rapid worsening overnight. He had a significant change in his mental status. He was minimally responsive. When they did get him to open his eyes, he had a lot of difficulty, but he was able to squeeze both hands to command, show thumbs up, move eyes in the direction that they told him to move them in, but he was just not speaking. And as far as they could tell, when they had him do the eye movements, he had dysconjugate gaze, just primary gaze. He could not look up and he did not seem to blink to threat. And this is his repeat imaging. I can refresh your memory if you need to, but he has more extensive involvement. I have the T2 flare at the top and post-contrast at the bottom. More extensive involvement of the pons and the cerebellar peduncles. It seems like there are areas that are less defined, kind of hazy white matter involvement. It goes up through the midbrain. It's in the thalami. It's bilateral. It goes all the way up, and he still has. He has new enhancement, and most of them, it seems irregular. They're not completely ringed. They're not homogeneous. They're just patchy. Maybe the one, if you look at the bottom right of the screen, maybe that's close to almost a ring of enhancement, but it correlates at least to the significant change in his mental status. Okay. And now, even though, there was a question of at one point, did he have some, enlargement of his spinal cord or thickening without any lesions? Now he seems to have had a new lesion at around C5 and possibly a little bit higher to discrete. And then here we have, you can see it on axial, it was the C5 lesion at least was associated with post-contrast enhancement. So I wanted to take a break and see what you guys are thinking now, or if this changes things, how you felt about ADEM in the first place, all of those ideas.
So I think now might be an interesting time to do hands again. Well, actually, no, let's not do hands yet on a vote of the diagnosis because we have hands up that we need to answer, but then we can take a vote. We've got some interesting comments in the chat. I'm going to throw them all out at you quickly. One is from Gina, was the NMO test cell-based? And Jessica wants to know if he got imaging at this time point of chest, abdomen, pelvis.
Yes, he did get imaging chest, abdomen, pelvis. That's coming up next. The NMO, I do not believe, I meant to look this up. It's sent to LabCorp. I'm not sure what they do. So I'm not sure if it's cell-based.
It might have been a license. And then Thomas asked about HSP 70 or the 68 KD inner ear antigen antibody.
Well, that was not sent.
Okay. And then Mike has a question about the spinal cord MRI. This new one is a change, right? The earlier one didn't have signal change or leptomeningeal enhancement.
Exactly, and I can take it back here.
And then we've got, I'm sorry I didn't catch who put their hand up first, but I think we have Dr. Yu, Dr. Perez, Dr. Pineda have their hands raised if you want to weigh in at this juncture. Start with Dr. Yu. You're on mute.
Sorry, a quick question. What kind of factory did he work in? What type of materials and exposures? And then I just want to clarify, after that first time he was put on a prednisone taper and then was off when he represented, is that correct?
Mm-hmm, mm-hmm. And he works in a plastic factory. He works with plastic.
Okay. All right, Gina.
Yeah, thank you. What about any exposure to COVID or any reason to think that he might have had COVID recently?
No, there's no reason, or at least that he knows of, that there was exposure to COVID. He did get tested back in the very beginning in June, but not in February before coming to us.
And would you mind going over the slide of the CSF studies again real quick, please?
The original ones?
Or yeah, because there were no localized events, but okay, thank you.
Mm-hmm, mm-hmm. This was repeated. Well, I guess that was a follow-up question I was going to ask, but yeah.
And then we have Mike and Siddharth both have their hands up.
Hi, thank you. So with the second event involving the other side, the other facial nerve, I am thinking now that, of course, this is a multiphasic event. It could be either, what comes to mind is neurosarcoidosis or lymphoma. Did we do imaging of the chest, abdomen, and pelvis? And
yeah,
if it was negative, yeah.
Yes,
if it
no,
was negative, will we do a
did
PET
that.
scan?
That's all coming up, yes, but
Oh, sorry to
that
preempt.
was definitely a consideration. Yeah, at this point, we were trying to broaden the differential. I'm not sure if other people have hands up or what they wanted to also note.
Well, let's get Siddharth because he hasn't had a chance to speak, and then I think we'll move on because I know you've got about 5 more slides. So Siddharth, and then we'll move on and then open up for faculty discussion.
I was also going to ask about chest imaging. I mean, looks to me maybe a predilection to the basal meninges, and that could be seen in neurosarcoidosis. I was wondering, has this person had like recurrent pneumonias and never really went away, or bronchitis in the past? Any unusual rashes?
No, he was previously healthy. This is his first time ever being sick.
Okay.
Okay. In the interest of time, we're going to let you finish, so we have a little bit of time left for discussion. So go ahead and take us through the last few slides.
Okay. So he got repeat CSF studies. His opening pressure was it was elevated 28. His basic studies were similar. We repeated the bands. There was none in the serum, none in the CSF. IgG index was normal. He had repeat cultures. The cytology said there was atypical cells, but there was limited sample. They couldn't get the flow cytometry. He had a repeat LP in which they did have enough, and there were no atypical cells seen, and the flow cytometry was unremarkable. We did test for soluble IL-2 receptor. In addition, we added the encephalopathy panel in the CSF and in the serum. And that was negative. Also in the serum, we'd added some B12 again. You can see all the ones I've listed, some other rheumatologic screenings. We also sent, in addition to repeating the aquaporin 4 MOG and sending them to Mayo, we sent MATA antibody panel just because I wanted to kind of highlight that He had some this bilateral thalamic involvement and maybe, you know, some limbic predominance. So, and he was a young male, so that's why we sent it. The additional testing that everybody was interested in, his CT was normal, no lymphadenopathy. We got an ultrasound of his scrotum and testes, it was normal. The PET of the brain and the whole body showed diffuse cortical hypometabolism, but also hypermetabolism in the basal structures, medial frontal, bilateral mesial temporal, and they thought this was consistent with limbic encephalitis. In the PET scan of his whole body, it was didn't have any evidence of neoplastic process, but they thought maybe there was an interval development of an infectious process in his lungs. He did have a cough noted in some of the progress notes, but otherwise no other signs for infection. I can skip on in the interest of time. So he got 5 days of IV methylprednisolone. He had some improvement in his wakefulness, but he still with repeat MRIs at that point still had some significant enhancement. He got plasma exchange. He was started on prednisone at 60 with a very slow taper, with the plan to follow up with the Mellon Center as an outpatient. He had 2 MRIs in rehab that were improved, and including there was no enhancement in that cervical spine. And the last imaging that he had was April 30th at this point. And so the decision was to give him a dose of rituximab. He got that in June, but he started having a worsening of all of his prior symptoms, including his cognitive deficits and his language in particular. And so he had a repeat MRI, which he was supposed to have, you know, we were doing close monitoring, and it was worse. So I just wanted to kind of highlight the images that were worse. So he, at least in April, he had at least almost all resolution of his contrast enhancement. The previous flare abnormalities, T2 flare abnormalities, also seemed to kind of resolved. But if you look on the right in July, I kind of matched him up a little bit. He definitely has some worsening with some new enhancement as well. So at that point, well, I can see what people
Should we stop here? Because I think you get the answer on the next slide.
Yeah.
Anybody want to just shout out in the chat what you think the patient has? And does anybody want to actually say this is MS? Or anybody want to, fellows want to shout out what you think the patient has? Or put it in the chat, because I think we get the answer on the next slide. Siddharth has his hand raised. Maybe he wants to take a stab at the diagnosis.
Oh, sorry. I think my hand was still raised from before.
Oh, okay.
I'm not sure. I'm still hedging on maybe isolated neurosarcoid, but that's.
We got a vote for neurosarcoid. Any other votes? You can just shout it out quickly.
Not MS, maybe vasculitis.
Vasculitis?
Maybe he needs a brain biopsy.
Brain biopsy sounds like a good idea. Any other fellows who haven't spoken up today or want to weigh in before she gives us the answer? Dr. Zabad, we are about to open up discussion, but did you want to give a vote?
I am not convinced that this is anything demyelinating. It reminds me of a case I had. He had a germinoma that went to the brain, but we found the tumor on the PET scan, and it was in the chest because germ cells migrate from the chest to the testicles, and then there are some residual cells that can, if there is a germinoma, it can go to the brain. So I would love to have a biopsy and the tumor marker first and then biopsy.
Okay. All right. Well, give us the biopsy, Dr. Rose.
Okay. He had a mature aggressive diffuse large B-cell lymphoma. And they did induction with methotrexate. Now he's in his second cycle of this plan. He's not worsening, but he has some residual right greater than left facial droop, still has balance issues, still has memory deficits, and he's got some depression. which is understandable. I just thought this was an interesting case to kind of point out because, especially in young men, we tend to, or at least I don't tend to think about diffuse large B-cell lymphoma with the spinal cord involvement like this. And I looked it up, and apparently 3.3% of all primary CNS lymphomas involve the spine. I don't know how true that is still, or if that's what other people's experience has been. But that's just why I like the case.
Great job and really interesting case. All right, we've got lots of hands going up. We'll start with Gina, our fellow, and then Scott and Raina.
Oh, thank you. That was a great case, Rose. I have a question mostly for the faculty. What do you think about giving that rituximab at the very beginning when the diagnosis wasn't very clear? Like, could that have been maybe premature, or was it like I just find it hard when you don't know exactly what it was. When do you commit to starting immunotherapy, or when you just wait?
Good question. Would you have voted, Gina, to do the biopsy? It's hard to know, right? You know, biopsy is pretty invasive, but you're wondering if maybe you would have biopsied before the rituximab. It's a good point, good question. Yeah. All right, Scott Newsom, Raina, and Bob Lissack, I see hands up.
I'll just make two quick comments. So one on the MRI, what caught my attention was there was really homogeneous enhancement in some of these lesions versus heterogeneous enhancement that we often will see with neuroinflammatory conditions. And so that was one thing that was like, well, you know, higher in the differential for me when I see that is lymphoma, even in a young person. The other MRI characteristic that was unusual was you almost got the sense of this progression from one hemisphere to another. And there was sort of this tracking appearance, which again, lymphoma, GBM, PML, you know, it's all the things that we learn about, which some of those are textbook, but we do see them even in young individuals. So I just wanted to point those two things out. And I give Deja a lot of credit, the MATA. I loved it because when I saw the initial MRI and the diencephalon involvement, I was like, young man, MATA encephalitis, germ cell, dysgerminoma, and then obviously it wasn't, but great thinking and working this patient up.
Absolutely. Okay. I think it was Raina and then Bob.
Yeah. Couple of things. So this would be the third or fourth lymphoma in the brain that I'm seeing. And every time I'm shocked how much the location looks like demyelination, but the shape and the morphology does not look like demyelination. So if you look at the lesion, like it looks periventricular, early one, like even the lesions around the fourth ventricle, you would swear that this could be a demyelination, but the lesions are very irregular. That's number one. Number two, I know nowadays we don't use a lot of CAT scan, but one way to differentiate demyelination from a lymphoma on a CAT scan is that lymphoma are hyperdense versus a demyelination. Usually the lesion is hypodense. And a lot of time we don't pay attention to that because we don't use CAT scan anymore. Or at least we don't use them in that context.
Yes, great points. Bob? Dr. Lissack, are you still there?
I'm here. So I think Raina's point and Scott's point about, you know, sitting right up against the ventricle with a regular shape and not one Dawson's finger in sight really smacks of lymphoma. And I've seen one case that did involve the cord, so it is rare. The other thing I wanted to just ask early on, but the patient wasn't at the Cleveland Clinics at the time. Did the patient have Bell's phenomenon when they had unilateral and then bilateral weakness? Because one clue that your peripheral seventh isn't so peripheral is if you don't have a Bell's phenomenon, it suggests that the lesion also involves the tracts descending. Whereas a classic peripheral 7, you get a Bell's phenomenon. A negative doesn't help you, but if you don't, a positive doesn't help you. But if you don't see a Bell's phenomenon, and the story really wasn't the classic for Bell's palsy, that's an alerting sign that you've got something in the brainstem, not just the peripheral nerve.
And fantastic point. There's some points in the chat also.
Oh, I also wanted to know, did they do HIV and EBV in the CSF because some B-cell lymphomas, usually in the presence of HIV, Alex Sellis liked to point out that they're often EBV positive, but I don't know if this was checked.
No, it wasn't.
Another great point. Mike points out that the basal ganglia involvement was also a warning sign possibly for lymphoma. And Brigitte is also mentioning, that warning sign of those few atypical cells, and that rule of doing 3 taps to rule out lymphoma seems to be salient. This patient looks like they got 2, didn't get the 3rd. Unclear if you might have had to go on to biopsy no matter what, because that second one looked pretty good, the second tap, but maybe it's an illustration of that rule of trying to get 3 taps to rule out lymphoma. Other thoughts?
I think he had 3, right?
Oh, he had 3. Okay, I missed the 3rd one. Okay.
They were 2 side by side on one slide.
Yeah, he had. They were 3 days apart.
So that rule doesn't hold up. You still have to get a biopsy. Okay, let's see if we have more hands up. I think those are still the same hands. Other thoughts about the case?
Well, I was going to mention that I think the 3 LPs, large volume LPs, is sort of a past phenomenon. At least at Hopkins, we're going right for the biopsy. We're not wasting time to do three LPs. Just given the severity of this case, you have plenty of areas to biopsy. And I think prior to committing someone to an immunosuppressing drug like rituximab maintenance, certainly I would go ahead and go for the biopsy where the money is. It's tricky though, right? The person got steroids, so that clouds the picture a little bit. So the biopsy may be affected by the steroids, but biopsy definitely.
Absolutely. If it's accessible, I have to say there are some cases where it's hard to get at something, and then I still think it's worth doing a few taps, but it's a good point that if it's scary and you're really worried about lymphoma, probably the faster you get to biopsy, the better. Any other thought? 2 wonderful cases today. Any other thoughts or comments, feedback on any of the 2 cases? I think we had a record number of fellows interacting today. Truly, well over the norm for fellows commenting. So great job, great discussion.
Awesome. I have one quick question. One thing, it looks like in CSF, his lactate was elevated. Is it typical for lymphoma, or was he having something else? Maybe was he having a seizure at the same time that could contribute? I was wondering.
He was not having seizures. I don't know why it was actually checked.
Is it lactate dehydrogenase, LDH? Because that's something that is done with lymphomas.
I think it was lactic acid, wasn't it?
It was just lactate, yeah.
Yeah, it was lactate. I would defer to Dr. Lissack. He's probably the most seasoned out of all of us. I don't know if he's still on.
There's a few comments in the chat here. It says, for the hive mind, do your institutions spin CSF for higher cytology yield? And Alex also brings up that sometimes people invoke the rule of 3 taps, but aren't really doing high volume taps. And those are both, I think, really good points. The rule of 3 is for high volume, not 2 to 3 cc's, which sometimes happens. And you're right, that'll affect your yield for cytology. Okay. Well, Scott, I don't know if you have any other comments. Hope, but a great job, guys. Excellent job presenting. Great discussion. Look forward to the next seminar next month. Any other final comments, Hope or Scott?
Or other faculty?
Or other faculty?
All good.
All right.
Okay.
Awesome.
Have a great
Thank you, guys.
Okay, thank you.
Thanks, everyone. Have a good night.
Bye-bye. Good night.